So I'll be talking about the marginal zone lymphoma. I'll be talking, I'll be rather giving the overview about the marginal zone lymphoma. We have heard about the aggressive lymphomas. We have heard about the not so aggressive lymphomas. But what I'll be talking about is one of the most indolent lymphomas that in my mind exist. That is probably less indolent or more indolent even as compared to the follicular lymphoma that was just discussed by Dr. Pravas Mishra. So again, thanking all the organizers. So the outline for my today's talk is I'll be talking about the introduction, the subtypes of the marginal zone lymphoma, that is a nodal, extranodal, and the splenic in specific, the histological transformation that is associated with these type of low grade lymphoma, what happens in the relapse setting, and finally a brief outlook on the role of autologous transplant. Yes, there is a role of autologous transplant in indolent lymphomas as well. So marginal zone lymphoma is the second most common type of indolent lymphoma, comprising 7% of all non-Hodgkin lymphomas. There are three distinct subtypes. Extranodal, that's the most common subtype and comprises almost 70% of the marginal zone lymphomas, followed by a splenic marginal zone lymphoma that comprises almost 20% of the marginal zone lymphomas, and the last one is the nodal marginal zone lymphoma, that's supposedly the least common of all these. So the problem is these lymphomas, having said that, discussed about the frequencies in these high percentages. The problem is these actually very less in number. The rarity of these lymphomas are so high that the actual data compilation based on formulation of guidelines essentially comes down to the incorporation of other indolent lymphomas into the category, and then how the guidelines on the marginal zone lymphoma are formed and sort of interpreted. So there are three interesting points about this category of lymphoma, or I should say this subcategory of indolent lymphoma, and that is there is a strong association to infections. Have you heard infections being caused by lymphomas or the blood cancers being caused by infections? So that way, the first in list comes the marginal zone lymphoma. Second thing, have you heard about the autoimmune diseases ultimately leading to cancer? So again, marginal zone lymphoma is supposedly one of the highest rating disorders or cancers or lymphoma that comes into picture when we are talking about autoimmunity related lymphoma. And then of course there is a role of genetic component. We all know about SLL and CLL that have got a strong genetic background. In addition to that, the second lymphoma that comes into play is the marginal zone lymphoma. So three important etiologies that are associated with marginal zone lymphomas are infections, autoimmunity, and presence of genetic risk factors. So this I'll be talking about. So yes. It's like Sjogren's syndrome, as I'll be talking subsequently also. In patients with Sjogren's syndrome, there is a high prevalence of salivary marginal zone lymphoma. Then patients with Hashimoto's thyroiditis, there is an increase in incidence of thyroid extranodal marginal zone lymphomas. So this is how, and there is some prevalence of increased frequency of marginal lymphomas in patients with metal workers, in patients with asthma. Again, all these are possibly related to the autoimmune backgrounds. So the first and the most common type of marginal zone lymphoma is the malt lymphoma, mucosa associated lymphoid tissue. So wherever there is a mucosal membrane and there is a lymphoid tissue beneath the mucosal membrane, those sites are prone to develop mucosa associated lymphoid lymphoma tissue, and then it progresses to lymphoma. These are essentially associated, we are talking about mucosa. So these are often involved by chronic antigenic stimulation, and whenever there is a chronic antigenic stimulation, we know that these patients can transform into lymphoma. So malt lymphoma essentially leads or is a result of chronic antigenic stimulation because of whatever infection. So as we are talking, infections lead to malt lymphoma. The most common site for these malt lymphomas are the gastric malt lymphomas, responsible for almost 30% of the total cases. And the other common sites, one is the ocular, the skin, the ocular adnexa, and the salivary glands and the lungs. So these are the commoner sites where these extranodal things happen. So autoimmunity, as I have discussed this thing already. So the interesting point is, as I was discussing, these are a very indolent category of lymphomas. So many a times, even if you treat the infections that is leading to these type of lymphomas, that is sufficient enough treatment to cure these lymphomas. So very indolent category of lymphoma arising many a times because of the infections, that should always be in your mind whenever you see a report of a malt lymphoma or a marginal zone lymphoma. So the common infections, as we discussed, one is the H. pylori that we all know about. That's a causative factor for malt lymphoma of the stomach. Then there is the role of chlamydia, Sitaki in chlamydia sitaki in the genesis of ocular adnexal malt lymphomas. Then there is role of this Acromobacter xylosidans in the generation of lung associated malt lymphomas. So histological transformation is not so common, but yes, when it's there, it's a bad prognosis. That's one of the bad prognosis in patients with marginal zone lymphoma. And usually these patients have a second hit with some genetic alteration, essentially the TP53 or the P16 loss. So these are the common genetic mutations when it leads to histological transformation in these patients. There is a genetic component that usually involves Notch gene signaling and BTK gene involvement in the genesis of these type of lymphomas, and that is why there is a significant role of ibrutinib in the second line treatment that we shall be discussing subsequently. So how do we treat these type of lymphomas? The extranodal lymphomas, that's a malt lymphomas. First, I'll talk about the gastric malt. Gastric malt, we know, we discussed, it's H. pylori associated. You have to treat the H. pylori with a combination of PPI and a 2 or 3 antibiotic regimen, whether it's moxicillin or clarithromycin. This results in 75%. Two-thirds of the patients will be completely cured with the treatment with a H. pylori eradication regimen. So it does not end there. Beyond treatment with a MAC regimen or a sort of H. pylori eradication treatment, beyond that you need to get a urea breath test 2 months later after the treatment has been done, and that subsequently has to be followed by a repeat endoscopic biopsy to confirm whether the lymphoma has whether it has completely disappeared or not. If it has not disappeared, then that means probably the patient has a translocation 11-18 sitting somewhere, and that needs to be further evaluated and some treatment needs to be provided beyond that. So these patients with 11-18 translocation, even if it's a localized lymphoma, they have got a bad prognosis because there is a genetic component involved there. So for these patients, so there is a role of the eradication treatment, H. pylori eradication treatment, even in those patients who do not have a H. pylori documented. Even if they are negative for H. pylori, those patients, 20% patients of such patients can also still be treated with a eradication regimen. They can get benefited. Beyond that, of course, if they're not benefiting, there has to be some alternative treatment. And the most important of them is 2 treatments. Again, so whenever there is an infectious treatment not working out for a localized disease or maybe a widespread disease, the treatment that comes into play is twofold: localized disease or a less extensive disease. In those patients, you have the options of giving IFRT, you have the option of a rituximab therapy, or you have an option of a surgical removal of the localized mass. So these are the options whenever you deal with a localized or less extensive disease that is not responding to the infectious agent therapy eradication, and then these treatments can be sort of incorporated. For those patients who have a much more extensive disease, of course, then comes the role of CIT, that's a chemoimmunotherapy that we shall be subsequently discussing about. So what happens about the non-gastric malt? So we discussed one of the commoner sites is the ocular non-gastric malt. And again, the etiological agent that is chlamydia can optimally be addressed by first testing for chlamydia sitaki. There is PCR test. There are IgM based tests that are available for chlamydia testing. And if they are positive, the patient may sufficiently be treated alone by doxycycline. So you give a course of doxycycline, the treatment is done, the lymphoma resolves, it's done. No more treatment is required. If that does not happen, the ocular mass is not resolving after the cycle of the course of doxycycline or clarithromycin, then probably it's time to incorporate some other agent. And in those settings, again, the most common setting is if it is surgically removable, good. If not, then rituximab monotherapy might be a good enough option, or even a involved field radiotherapy might be a sufficient option to deal with these type of patients. So yes, there has been a proven role of IFRT because this was a mentor-mentee concept. I have not gone into the details of the studies that are actually published, but yes, so there are good data that supports the use of IFRT and single agent monotherapy in these patients that can ultimately be benefited by long-term cures. So as we're discussing, these malt lymphomas have got a specification. They're curative. Other type of lymphomas that we'll be discussing, there is a nodal and the splenic ones, they're usually not curative. They keep relapsing. But these type of malt lymphomas, if they're treated optimally, they can get cured. The progression-free survival rate in these patients is higher. It's almost 85-90%. So for site-specific disease, the sites that are commonly involved with these type of malt lymphoma is the treatment, the first choice, second choice, and the later choices. Again, as we discussed, rituximab and radiation becomes or stands out as the most common employed and the effective treatments. Beyond that, if it is more extensive, not responding, then maybe chemoimmunotherapy. And at the last resort, we always have an option of the what Dr. Prashant is expert about is about the autologous bone marrow transplants, even in marginal zone lymphomas. That will be subsequently discussed. So this is about the advanced stage. If it is advanced stage, wait and watch. Of course, that is applicable for all indolent lymphomas. If it warrants treatment, then chemoimmunotherapy, different regimens, similar on the lines of what Dr. Pravas mentioned about follicular lymphoma. The trials have not been much different. It has been a composite trials of indolent lymphomas, wherein majority of the patients, 70% of the patients have been the follicular lymphomas, remaining 10-15% have been marginal zone, and the remaining have been CLL. So this is a broad outline of the trials that have been conducted in indolent lymphomas, and based on that data, it is suggested that yes, various immunochemotherapy, both bendamustine rituximab, whether it is RCVP, and what we recently what we commonly use in clinical practice is to take a call whether a RCHOP is required or maybe a less aggressive chemoimmunotherapy is required, is based on the Ki-67 index. So if Ki-67 is pretty low, we try to restrict ourselves to BR and RCVP like regimens. If it is higher, then we do try to incorporate anthracyclines in the treatment regimen. So that's a schema for treatment. If it's a gastric malt, eradicate the H. pylori. If not working out, or it's a relapse, go to a radiation or a single agent rituximab. Or beyond that, if it is still something else is needed, you can at any point of time go to a systemic treatment. Similarly, the same thing applies more or less for the non-gastric malt lymphomas. Surgical treatment alternative is radiation rituximab or a more conventional treatment. So what is important and interesting here is what happens if these patients relapse. That's just shown in the last slide, and that is that ibrutinib stands out as the most preferred treatment regimen. So ibrutinib, it's a BTK inhibitor that is highly expressed in most of these lymphomas, marginal zone lymphomas, and that is why ibrutinib has shown a good success. And there are now trials that are incorporating ibrutinib into first-line treatment for marginal zone lymphomas. And the other regimen, that is the other drug and the other molecule that is important, is the venetoclax. So that is again a BCL2 inhibitor. It's actively apoptotic disease. And because of that, there is a significant role of venetoclax as well in the treatment of these lymphomas. So the second and the least common type of marginal zone lymphoma is the nodal marginal zone lymphoma. The median age of presentation is elderly age group. Histological transformation is relatively more common as compared to the malt lymphomas, and it is associated with another infection, that is Hep C infection. So if there is it's not so common that Hep C so the incidence of nodal marginal zone lymphoma in Hep C infection is, yes, there is a possible association between Hep C and the generation of this type of nodal marginal zone lymphoma because of chronic antigenic stimulation. Similar to the paraneoplastic, or similar to the Hep C manifestation, that these patients can have IgM monoclonal as sort of serum monoclonal IgM elevation. Similarly, in patients with nodal marginal zone lymphoma, whether they are associated with HCV or not, but these patients can have a IgM elevation in almost 10% of the patients. So that is a significant finding, that if there is a IgM present, you should not miss it. Always there should be differential of Waldenstrom. Yes, that's always there. But beyond that, the possibility of nodal marginal zone lymphoma should always be kept. And similarly, we know that all indolent lymphomas, for that matter, can have some paraproteinemia. So those low indolent lymphomas will need further workup to evaluate it. Just to highlight that it's all IgM paraproteinemia. It does not mean that all have Waldenstroms. There can be other type of indolent lymphomas as well. So the problem gets complicated when you test for MYD88 and that comes positive. So that can come positive in almost 10% patients of a nodal marginal zone lymphoma as well. So what do? You send a NGS, you send a Sanger's, and maybe you get a mutation tested for one of these mutations that are lesser commoner but more specific for identifying a marginal zone lymphoma. And these one, especially the PTPRD one, that's seen in 20% of patients with the nodal marginal zone, these are rather specific, more specific for the presence of a nodal margin. So this is phosphate tyrosine mutation, that is kinase mutation, that is quite specific for the nodal marginal zone lymphomas. So how do we treat? The same principle. We treat the infection, HCV is present, you treat with HCV infection, the disease is gone, you are happy. If the disease is not gone after the treatment, or if the patient is HCV negative, then you treat with a single agent rituximab or use a single agent involved site radiotherapy. So there is a high role, as Dr. Prashant was mentioning, there is a high role of radiation oncologists in the treatment of these lymphomas. And of course, there is a more extensive. So I'll just wrap up with the splenic marginal zone lymphoma. That's the last part. So splenic marginal lymphoma is the second most common of marginal zone lymphomas. Median survival 8 to 10 years, can transform in significant number of patients. So what was interesting is why a particular person will have only lymphoma that is related to splenic zone. So I was just trying to search out Why a person will have a lymphoma that's restricted only to the spleen and nowhere else it's present? So it's essentially related again to the antigenic stimulation. We know that all the antigens ultimately are going to be processed in the spleen, and ultimately the marginal zones that are surrounding the innate lymphoid cells, they get stimulated by the cytokine storm and the profuse amount of cytokines that are present there, and they get constantly activated, and that ultimately leads to the splenic marginal zone lymphoma. Here there is a important role of notch pathway that is more important in these type of marginal zone lymphomas as compared to the other ones, and there are some other sort of mutations that are also common in these type of mutations. So morphologically, there are morphologists, and of course the diagnosis of splenic marginal zone lymphoma can also be suspected on a peripheral smear. I think Dr. Gaurav is there. So there is a possibility of identifying a splenic marginal zone lymphoma on peripheral smear. There is a typical cytoplasmic blebbing pattern that is common in and that can differentiate from hairy cell leukemia, and that is the bipolar versus circular presence. So how do we treat that? Again, same principles. There is no involvement of infectious agent in the splenic marginal zone lymphoma. That's the exception to that. But having said that, the other treatment indications remain the same. So if the patient has a symptomatic splenomegaly, if he's got cytopenias and that are troubling him, the patient has got systemic symptoms or a progressive nodal disease, then these are the indications why these patients would ultimately need some treatment for these type of. And how do we treat them? Splenectomy, rituximab, or a more conventional chemoimmunotherapy. So splenectomy, after the advent and the availability of rituximab, has gone down in the treatment armamentarium, but of course that's the only curative treatment possibly available, and that removes a significant bulk. Abdominal discomfort can be removed much more faster. That's the advantage with splenectomy. Rituximab monotherapy has been significantly effective. Of course, we all would have seen recently, we had a patient, splenic marginal zone lymphoma, not responding to any treatment, undergone autologous transplant, relapsed 6 months after that. So sometimes these type of nasty lymphomas are so bad, you do whatever, you cannot get over it. So there have been trials, resort trial of rituximab sort of induction weekly into 4, followed by maintenance once in 3 months, and they have shown a significant benefit in sort of achieving longer TTF and treatment-free survival and a progression-free survival in these patients. Chemoimmunotherapy, all sorts of regimens that are available, as mentioned by Dr. Pravas, can be used or for the splenic marginal zone lymphoma, and that's the sort of just a flow diagram. And how do we achieve? And that's what we discuss. If it is HCV positive, treat the HCV. If it is HCV negative, treat the with the single agent rituximab. Radiation does not have a role, of course. It's a spleen is the site. Radiation does not have a role, and you can use either a rituximab monotherapy or a chemoimmunotherapy for these type of patients. Again, ibrutinib is an important treatment that can be sort of histological transformation, 1% incidence per year, and the chances of sort of higher can be more. The histological transformation can be more if the patient does not achieve a complete CR, elevated LDH, more than 4 nodal sites, more than 5 mucosal sites. All these sites are predictors of histological transformation. The novel agents, I think this chart we would have seen multiple times, but the more important one is the BCR signaling, the Bruton tyrosine kinase, the phospholipase C, the protein kinase C. All these can be combinedly inhibited by ibrutinib. So that is the most important molecule that is available. The second one is the mitochondrial apoptotic protein BCL2 inhibitor. The third one is the co-receptor CXL2 inhibitors, PI3K inhibitors, and of course the BCR signaling inhibitors, that's a CD19 and CD20 inhibitors that are commonly available for these patients. Relapse setting, there are a host lot of molecules, but as we discussed, the standout ones are ibrutinib. Role of autologous transplant, of course, people like Dr. Prashant and us, we get thrilled when it's talk of autologous transplant. Of course, in indolent lymphomas as well. So there is a retrospective that study. This was published in 2019, and that was a composite marginal zone lymphoma patients of 199 patients. The median number of therapies that were given to the patients had a chemosensitive disease. The patient had a chemotherapy-based 89% of the cases. So, now what is important and interesting is in what study this study showed up was there is now an increasing trend of incorporating the transplants in the non-malt. So nodal and splenic marginal zone lymphomas are more and more tried up for an autologous transplant, and the transplant is being slowly brought up early. The 5-year event-free survival is more than 50%, and the OS is 73%. It's expected. I believe this OS is pretty low. It should be more than 85%, considering it to be an indolent lymphomas. But yes, it's an open debate, the role of autologous transplant in these type of lymphomas. But what we should restrict and what we should convey to our mentees is that where it should be incorporated, and that is the aggressive presentations of these lymphomas when they are more widespread, and the patients do not achieve a remission upfront after the upfront chemotherapy. Maybe 2 salvage lines have failed, and if there is mainly a nodal involvement. So these are the common places in which where we should sort of incorporate this. I think if there are any questions, I'll just.
Anyone? Yeah, please.
So the traditional teaching is that all the indolent tumors do not, the radiotherapy doesn't work in indolent tumors. Why is it that it works so well in indolent lymphomas?
One of the radiotherapists can answer this, but there is an exception that these are the only type of indolent lymphomas that respond so well to the radiotherapy. I believe your question is valid, but I think one of the radiotherapists.
So I think Dr. Bhaskar and Dr. Nivedita can.
So basically, they're indolent tumors, right? So they're more radiosensitive. And the gastric malt has found to be that radiation alone, I mean, if upfront, those with translocation 11, 19, 18, they're resistant to the H. pylori treatment, right? So we have to give a local treatment. I mean,
cells should be more sensitive, but here are the cells probably not so rapidly proliferating. Then why the radiotherapy is working so well in there? So that's probably the question that you're asking.
It could depend on the P53 and other aspects wherein which it could be involved, which could have a bearing on, even though it is indolent, it could have, because of the natural history itself, could contribute to the response of radiation. We are not really sure. We are really not sure about it.
I think I can just give one comment, because these are indolent diseases. So PFS is anyways going to be long. So if you treat them, it's going to sound like they have responded very well, because they will not recur very soon. So that is probably the biology of the disease which answers your question. Yeah. So I think now if we can have one more question if anybody wants to ask. Yeah, please.
Yeah, identify gastric tumors. If we identify 1180 translocation upfront, can we still put the patient on it?
If he is pylori positive, has to be treatment first. Even if he is at 1118 positive.
Okay.
So if the patient does not respond to that treatment or relapses at some point, then only you require second line.
Okay.
I think so. Meet is regarding the antibiotic therapy for ocular red inexcel lymphoma. It's very important for the mentees to understand it's not a usual dosing of antibiotics. If you see clarithromycin, the dose usually is 250 milligram OD or 500 maximum. The dose employed for this setting is 500 BD, and that to be given for 3 months before you say or refute whether there is any response or not. So it has to be clear. The reason is because Chlamydia psittaci is a slowly indolent kind of and pervasive organism. So like you give antibiotic therapy for acne for very long, you have to give it for at least 3 months before you say it is not working. So the dose is important and duration is also equally important.